Ladies and gentlemen, welcome to today's webinar hosted by the Supportive Care Coalition and the Catholic Health Association. Today's presentation is titled Palliative Care and COVID-19, Implications for Clinical Practice, presented by physicians Olamuyiwa Adeboye and Greg Vandekeith, and bioethicists Nate Hibner and MC Sullivan. Before we get started, I'd like to mention that today's session is being recorded and you are currently in a listen-only mode. A large portion of today's webinar will be a question and answer period, so please use the questions panel on the right side of your screen to begin submitting questions at any time for our panelists to discuss. We also encourage you to share what you are doing to support healthcare staff during this stressful time, as well as links to resources that you have found helpful. We will share them after the session on the SCC website's COVID-19 resource page. If you experience any technical difficulties during today's webinar, you can click the Help tab at the top of your control panel or ask me a question directly in the questions panel. Now, without further delay, it is my pleasure to introduce your moderator for today, Denise Hess, the Executive Director of the Supportive Care Coalition.
Thank you so much, Brianne, and welcome everyone to today's webinar, as Brianne said, presented jointly by the Catholic Health Association and the Supportive Care Coalition. As I was anticipating joining you all this morning for this webinar, I was reminded of Jesus's words in the Gospel of Matthew. Come to me, all you who are weary and burdened, and I will give you rest. And for those of you learning about the Supportive Care Coalition for the first time, the coalition, amongst many things, seeks to be the kind of community where we can all gather and collectively find rest, find ease, find a visible and tangible reminder that none of us on palliative care teams, in healthcare settings of all kinds, are going through this alone. We have each other. So with that in mind, just to remind you all that you have access to all of the numerous resources on our website, and you have access to this community, this interdisciplinary community focused on advancing excellence in palliative care, and currently focused on being a place where you can find rest for your souls. And as Brianne mentioned, we did just want to walk you through a couple of the resources on our website. We have added a COVID-19 resource page. And for those of you on your computer, potentially, if technology cooperates, you will get a glimpse of our COVID-19 resource page. You can navigate to that by going to www.supportivecarecoalition.org. It doesn't look like it's coming up right now. We'll try again at the end of the webinar. And similarly, here we go. So as you see under the resource tab on the header there of the website, the first item as you navigate to that page is our COVID-19 resource page. Our page is unique in that we cite and reference all of the other organizations, our colleagues in the field of palliative care, their websites, but we also have made it a repository of best practices, guidelines, ethical decision-making documents that have been contributed by our member systems. So we invite you to take advantage of the rich resources there, but even more so, we invite you to contribute to that repository by sending us your documents, your guidelines, things you are working on right now. In addition, caregiver well-being is exceedingly important to us right now. So again, just walking you through on the website, for those of you who can see on your computer screen, at the top of the page, there is a tab for caregiver well-being. Pretty much every day, we put a new post up there, and they are short meditations, poetry, readings, reflections, all specifically addressing how to downregulate our parasympathetic nervous systems is one way to say it. How to find ease, how to find a moment of rest, a moment of calm in the midst of what is a distressing and unprecedented time for all of us. So with those resources in mind, we're going to begin our webinar today. This is likely going to be one of 3 webinars just like this, where we have a panel of presenters and then an extended time for question and answer and sharing issues that you're facing. So today, we are especially excited to welcome 4 panelists to lead us in this time of discussion. Dr. Olamuyiwa Adeboye is the Medical Director of Palliative Care at Ascension Health. Dr. Greg Vandekeef is the Medical Director of the Southwest Washington Region of Palliative Care and the Associate Medical Director at the Providence Institute for Human Caring for Providence St. Joseph Health. Nate Hibner is the Director of Ethics at the Catholic Health Association, and MC Sullivan is the Chief Healthcare Ethicist and Director of the Initiative on Palliative Care and Advanced Care Planning at the Archdiocese of Boston. And the plan for our hour together today is to have our 2 physician panelists begin by describing some of the emerging clinical issues for palliative care teams in the midst of COVID. And then next, they will queue up our 2 bioethicist panelists who will frame these clinical issues in the context of Catholic ethical and social teachings. And last, we will have an extended facilitated Q&A session where we will hear from you. So as Brianne mentioned, all of you in your dashboard have a questions tab. We invite you at any time going forward to share your questions, concerns. You can even post in there resources that you have found helpful that we will add to our website. We will get to as many of the questions that we have time for today. And so without further delay, I will turn it over to Drs. Adeboye and Vandekeef. Welcome, Greg and Muyiwa. And we are so grateful that you have taken the time to share your expertise with us today.
Thank you, Denise. Morning, everyone. Greg?
Greg, it seems that you might be muted.
There, is my audio coming through well now?
Yes, it is.
Very well, thank you.
Okay. It's like a internet meme, sitting here talking away with my microphone on mute. So welcome, everyone, and thank you for your interest in attending this morning, especially for those of us out on the West Coast. It's very early, but yet this is such an important topic. I can see that people would get up a little early so that they could address it. I'm going to start by utilizing the article that is an article that is listed in the resources on your Supportive Care Coalition webpage, and it is by Downer et al. It's called Palliating a Pandemic. All patients must be cared for. And the principal consideration in this article is, amongst other things, the authors break it down into a variety of contexts that we must address in the setting of a pandemic. They break it down into 4 S's. The first is stuff. And in the setting of the current COVID-19 pandemic, stuff would qualify such as, what about protective personal equipment, which is becoming a bit of a challenge? In Providence St. Joseph Health, where I practice, we're a large health system. It was stated the other day that one hospital in our system has used as many face masks already in 2020 as our entire health system, with 51 hospitals, used in 2019. So in the midst of this pandemic, people are utilizing equipment, PPE, at a remarkable rate. Other things that would fall in the category of stuff, what are we doing to make sure that we have supplies to essential pharmaceuticals? Opioids, benzodiazepines are often challenging even in the best of times, but if we're in a time of shortage, are things like that going to become more of a consideration? And then, of course, the thing that most of us are fearing, what happens if we get to the point where the clinical need for a resource such as ICU beds and ventilators exceeds capacity? How are we going to deal with those sorts of situations when that type of quote-unquote stuff now is in scarcity compared to the demand? The second S that Downer and his colleague list in that article is staff. What are we doing to assure that the people that work in our systems are being well cared for, that they have proper guidelines to assure that they are limiting their exposure to this agent? And conversely, there's an internet meme out there. Don't think about how to prevent yourself from getting the infection. Assume you're carrying it and think about how to keep from spreading it to others. And especially those of us working in the palliative care space, we deal with patients who are ill, who are quite vulnerable. And so being mindful of how we protect staff. And then another aspect of staff that I haven't heard addressed with the depth I think it needs to be, what about the moral distress we're experiencing? I heard a very sad story from my primary hospital in Olympia, Washington yesterday of somebody who is dying of COVID-19 related complications. And because he's COVID-19 positive, he is not allowed any visitors. So how are we going to deal with families at one of their most vulnerable times of life to assure that they have access to their loved ones in this situation? But then coming back to the staff aspect, the moral distress that creates within our staff, and over time with accumulated events such as this sort, what about the moral residue that builds up? Because frequently after a single moral distress event, the moral distress doesn't fully resolve, and so the next event is building on a higher baseline level. And so thinking about our staff and what their needs are. And then finally with staff, just assuring that we have the workforce that's out there. If people are exposed and unable to work or need to be quarantined because of potential exposures, what are we doing to assure that the patients and the referring clinicians that we work with have access to adequate specialized palliative care resources? And of course, within that realm, the concept of telehealth has really taken off, which comes to the next S of space. Space in a pandemic is often considered around, are we creating specialized units, cohorting patients with the infectious agents so that we're trying to minimize exposure? Do we create wards of patients that have this? But then, both dealing with the PPE aspect that I mentioned earlier, how do we engage patients while utilizing as little of those scarce resources as possible, and going back to staff, while limiting our exposure of our staff and limiting our staff's potential exposure to vulnerable patients? And so again, space is really changing in the context of this current pandemic. When this article was released in 2010, telehealth was nowhere near as popular as it is today. And for many of us who have been working to try and build palliative care focused telehealth systems, this pandemic has served as a tremendous catalyst, and we are seeing innovative ways to utilize virtual encounters, whether it be to engage a family with, I heard a story last night of a daughter in the waiting room while her father was dying in the ICU. They could not bring her in to be with him, but the ICU nurse was able to bring a iPad to the doorway to allow the patient to be visualized by his daughter. She was actually able to say important things, including comments of forgiveness to her father in his final moments, from the emergency department waiting room using her phone connecting through the iPad that engaged her with her father. So space is changing dramatically in the setting of the current pandemic. And then finally, systems. All of the things I just described, staff, and space, need to have the support of systems in order to be effectively implemented. And some systems are really struggling to catch up to the pandemic. Other systems actually had fairly well-established protocols and procedures in place that now they're bringing them out following H1N1 or whatever might have triggered their development in the past, and bringing them up to speed for the current COVID-19 pandemic. Systems are going to do crucial things such as supporting the telehealth framework, such as developing policies and protocols around the decision matrix for the allocation of scarce resources, sometimes referred to as rationing. What happens when we get into that space, and how do we deal with it in a thoughtful and equitable and just manner? And then how are we supporting the staffing and the workforce issues to make sure that we have resources to meet the needs of our consulting clinicians and the patients, families, and communities we serve? Next slide, please. And with that, I am going to pass to my colleague, Moyawa, to talk a bit about other aspects of the role of palliative care teams in the COVID-19 pandemic. Moyawa.
Thank you, Greg. Morning again, everyone, and thank you for joining us. Greg has outlined beautifully a lot of what we think teams need to kind of start preparing. That article, I think, is a great one for everyone to kind of take a look at. My goal now is to kind of share a few things. What are the resources that are available out there? Denise has shared the SCC COVID-19 resource page. That is beautiful. It has a lot of information for everyone with regards to what we can do. One of the more important ones that I think I will call out is the Center to Advance Palliative Care CAPC resource page. I don't know how many people on here were able to listen to or have been able to listen to the webinar with Diane Meyer and Sean Morrison from CAPC last week. It's available, it's recorded. There's a lot of information in there. One of the things I think I would tell people is, as this whole thing is evolving, what we're seeing is information is also coming out at different paces for different people. What we'll see is it can get overwhelming, but what I would advise is each one of us know what our teams are able to do, identify who on our team is doing what and able to do what exactly. Some places already have team members who are working from home. So what can those team members who are working from home do to support the team members who are on the forefront? Our organization has some of our social workers working from home. We call in every morning, we have our huddle, kind of figuring out what's going on, and then we discuss and see what we can do. If we have consults, our social workers are able to reach out to family members from home and kind of talk to them about setting up meetings via the phone that we can all partake in if necessary. Those are some of the things that are out there. CAPC also has the symptom management toolkit for dyspnea, nausea, and a bunch of different symptoms that might prevail for patients who are COVID-19 positive. Now, what that means then is, in terms of stuff and supplies, is making sure that we're working collaboratively, hopefully with our pharmacists in our various hospitals, to make sure that some, if not most of those medications are available. And if they're not, what are the alternatives that we can use? And is there a plan if things run out? What do we do in that kind of situation? Then CAPC also has the on-demand webinars. I know one of the ones that really has sold out is the telemedicine impact. I think Michael Fratkin has been doing kind of on-demand webinars with regards to the role of telemedicine in palliative care. This is going to be new for some of us, and this is where innovation is key. At this point in time, we have to be very innovative in terms of how we're doing things. I think it also boils down to what we feel we have available. What happens at hospital X might not be available at hospital Y. Hospital X might be part of a larger system that has a lot of support that can be called upon, while hospital Y is kind of like a solo hospital and they're trying to figure things out. This is where applying all these resources to your own individual needs, I think, would be helpful. Now, again, as we're going through all of this, one of the things we'll realize is collaboration is going to be very key. So we're working with pharmacy, like I said. We need to probably work with IT. If we're dealing with symptom management, do we have a protocol in place for possibly what people call the comfort care order set? If there isn't one available, could one be made available? Or do we have it available on paper sheet kind of, and then have that available for teams? We know palliative care teams across board might get overstretched, and there's the whole issue of PPE preservation or conservation at this time. If we're not able to get to the bedside, how can we be available to the frontline clinicians? It might be making ourselves available by phone. Um, Greg just mentioned, having a family member in the ER kind of talking to their loved one in the ICU who's in the dying process with an iPad. That means working with the frontline nursing team to kind of help facilitate things like that. Of course, we have to be mindful then of making sure that we're preventing transmission with the whatever device we use and making sure it's wiped down and cleaned appropriately. Um, so this is in terms of resources. I think the other thing we need to also realize is at each site, figure out who's available to do what, make sure that we create some documentation that's available to the people we're going to be working with to let them know what we're available to do and when we'll be available. For some teams right now, what I've been finding out is a lot of people are kind of seeing that there's a lull of sorts before what might be a surge that happens later on. And so using this time to kind of make sure that the people that we work with, hospitalists, ICU physicians, ER physicians, know how to reach us if and when they need to reach us, know what we'll be able to do. Are we going to be there in person? Are we not going to be there in person? And things like that. Also supporting each other. One of the things that was amazing was when Sean Morrison mentioned last week that already they have part of their palliative care team members who are self-isolating because they're exposed. What would happen to your team then if one or two of your members had to do that? How do you cope? What do you do? And maybe working through probably some contingencies in that case to figure out how you're able to provide care. Some places already have chaplains not being able to go in. How do you work around all of these things? A lot of hospitals, I think, within our system are encouraging the utilization of social media resources, so WhatsApp, Google Hangout, Facebook Messenger, and things like that as means of communicating with family members within teams as well. And I think that's one thing we're going to look at. The other issue that I think was addressed by the CAPC webinar was how do we make ourselves available in a broader sense? So when we look at the role of developing policies and protocols around things, there's a tendency for us to kind of maybe want to be in the background and not put ourselves out there. But if we don't, and when literally things become a crisis situation, we won't know how to handle things because we have put ourselves in the background and have not let people know what we're available for. So I think working with your various hospital leaderships, the maybe director of patient care, the pharmacy team, the ethics teams, to know that, what, we're here, this is what we're able to do, how can we be helpful? Sharing some of these resources, the communication tips that come out from Vital Talk, that is very key. And I know a lot of places are sharing that with their frontline clinicians already. But one of the other things I've heard too is a lot of people have been overwhelmed with all of this information that's coming their way. And how do we manage all of that? I have seen some of our hospitalists print out some of those Vital Talk one-page resources and have it on their desks available just in case. That might be something just to do. It's like just in time. Or providing the SEC link to people, so knowing that. I think we need to be careful to make sure that the palliative care teams are not going to be the ones who will be frontline in making decisions about allocation of resources and things like that, because I think that would cause a lot of distress already to some very vulnerable team members, but also might take away from the roles that we would have in terms of being the primary facilitators of a lot of all these conversations. Greg, anything else? Greg?
So one role the palliative care team will need to play is to continue to provide clinical care throughout the enterprise. So with that, we'll move on to Nate and MC.
Thank you for bringing together the clinical aspects of palliative care in its response to the current pandemic. I think it helps to really transition us into some of the more ethical concerns. And so I'd like to start with kind of reminding ourselves what are some of the foundational ethical principles, missions, values that we hold not only within palliative care, but within the broader healthcare industry, within the broader Catholic healthcare approach. You know, for centuries, the Catholic Church especially has responded to epidemic upon epidemic. We have saints who founded congregations that help to accompany people who are at times of plague and pestilence. Everybody from Saint Bernard Ptolemy, who founded the Olavitan Benedictines, who actually have a health system in Arkansas. Their congregation helped in a plague in the 14th century in Siena. The Capuchin Franciscans gained fame and notoriety at the beginning of their creation about their response to a plague in their community. And I want to point this out not only as a call to action, that we have a history of responding to this need, but also about this very strong and embedded value of accompaniment, even in moments of extreme crisis and chaos. Palliative care has always been an excellent exemplar of accompaniment. How do we sit with those in times of great need? The second thing I think we need to always keep foundational when we discuss the trickier ethical decisions that'll have to be made is that our ethics that we use every day do not suddenly go away. That our physician groups in their professional duties, our hospital systems in their missions and values, and then the overall understanding of the moral tradition of healthcare and in the Catholic light continue to guide us even in times of crisis. And so principles around the care for the poor and vulnerable don't go away. Principles of stewardship don't go away. Protection of and respect of human dignity don't go away. In fact, it is in times of great stress that we kind of see the true colors of one another, and we want to be able to come out of this showing that we really do respect and value these principles, even when the going gets tough. And so I think we need to make sure that we don't just negate and lose everything that we've done and all the lessons and all the ethics integration and formation and our mission that we brought into our healthcare systems and professions during this time. But in fact, we need to almost stick to it even harder when we're being stressed as we are at this moment. And so we want to make sure we keep those two understandings when we get into the discussions of more particular moments of ethical quandary. And my colleague, NC Sullivan, is now going to bravely enter into some of those difficult decisions.
We can't hear you.
NC, you are unfortunately muted right now.
And some of my most brilliant thoughts have just gone to waste. But I just wanted to thank Nate for the good setup. I loved your point that our ethical practices, our ethical procedures and processes don't go away during this. There's a certain amount of, I think, panic in the streets, and we particularly hear it in the public media and some of our public officials, unfortunately. But we need to stick to our knitting in both Catholic healthcare and in the ethics of decision-making in Catholic healthcare. So, you know, we start our ethical process, our ethical consideration with fundamental questions, and they remain the same. What is my duty, and to whom is that duty owed? And typically, and still, the primary duty is to our individual patients, the person who is in front of us. And typically, we are now used to having to kind of expand that focus a little bit. We're used to the fact that we often have complementary or supplementary issues to deal with, and they are complementary or supplementary claims on our duties. And those would be to the institutions we serve. Many of us work with an institution or with a whole system. And increasingly, we are used to the idea that we ask the same questions when we're dealing with societal issues, and what could be more exemplary of that than what we're currently facing. We do find ourselves in kind of a unique situation these days, trying to look at the usual considerations in different and multiple ways simultaneously. There's not a lot of time for ordered thinking and saying, well, let's get back to that, let's parking lot that or this issue for a time. And I think probably for purposes of brevity here and giving plenty of time for Q&A, I just want to refer to a couple of things. An example of this idea of kind of looking at different layers of duty, different claims of our duty simultaneously is the whole benefit burden discussion that we're beginning to have, and we have every day. It's not a new discussion, but we're doing it in this kind of multiplicity of perspectives way, all at the same time, not in an orderly fashion all the time. Where assessment and actual collaboration and calibration of benefit of vent support, for example, is done in consideration of the patient in front of us, but mindful of the patients who are in the queue behind the patient in front of us. So balancing the claims to our duty is very often now and very much directed by the changing and sadly the increasingly limited availability of scarce human and material resources. So as I thought about how do we do this, how do we make that bridge successfully so that we can go back and forth over it from the patient in front of us, individual considerations of benefit and burden, to the larger, I found myself leaning more and more and more on the principles of Catholic social teaching. And Nate just mentioned some of them a moment ago, but I want to say two things before I actually recite them for us and how they might be relevant. First of all, they're not formulaic. You know, where many of us coming from clinical and scientific backgrounds, where we're looking for some formula that we can come up with to come to the right answer and resolve the problem in front of us. They're not, but they are helpful to us in the sense that we can tick the boxes and make sure that as we're trying to come up with policies, procedures, and actual decisions in the moment, we have considered a lot of different things simultaneously. By the way, I in my job here at the Archdiocese, I also work with all the Catholic facilities in the Archdiocese, not by system per se, although there is one particular system that I spend more time with, but for all of us who are Catholic and complying with the ERDs and grounded in Catholic social teaching and the teaching of the Church, probably one of the most interesting articles that I've seen came across my desk this week from one of the larger secular systems here in Massachusetts. And I'll send it to Denise and make it available to people who might be interested. What was striking about this very secular, it's from the public university healthcare system here in Massachusetts. What was striking was the constant threading throughout it of Catholic social teaching principles, and explicitly so. So let me, for those of us who need a refresher on what are the Catholic social teaching principles that I think will inform us and guide us as we not only create the frameworks and the policies and processes for decision making, and particularly around scarce resource allocation. Many of you have already created those. It would be late to the game, perhaps not to. But in the discussions for implementation, I'm sure many of the folks listening are part of a kind of pandemic response team for the institution or the system. But more importantly, I think as we get deeper and deeper into the actual experience of this public health crisis, I think many of you are probably on emergency response teams having to do with decisions at the bedside or in the ED or in the ICUs. So the principles, just in a quick refresher, and then I'm going to wrap things up so that we can have plenty of time for discussions. Life and dignity of the human person. And what was striking again from this secular group was the way in which they sought to remind us that means everybody. We might want to look at what the benefit of something is for the patient in front of us, given that we're now learning things like the cardiomyopathies that seem to strike a lot of particularly our male patients in ICUs who have been on vents for a while and are COVID positive. We're finding that maybe resuscitation isn't good for them. So that's a good clinical, scientifically based, if in fact the data proves to be true, decision to make. But simply because someone is over the age of 80 is not a reason to make the decision that perhaps they fit our exclusion criteria. The dignity of all human people is there at all places, at all times, regardless of their age or their medical history. The question of benefit for ongoing intervention, that's a different question, and there are other criteria that we want to look to for that. The call to family, community, and participation, that's the second principle. And Greg referred to the incredible on our headness of this moment, where at the time when people most need the folks who support them through these instances, they are separated. Patients in hospitals are not having visitors. Families are acceding to the stay-at-home orders, and even when we're close, we're 6 feet apart. There's no hugging, there's no touching, and all of that. So we need to remember that and compassionately keep it as part of the cornerstone of our policies and processes as we go forward. The rights and responsibilities of both the workers and the people receiving the benefit of their work. And how do we do that? Mindful of the fact that we are asking our healthcare professionals, our first responders, our grocery clerks to do things that the rest of us are being spared. How do we keep that in mind at all times? The dignity of work and the rights of these workers. The dignity of work has never been more publicly saluted. So I think we're pretty much okay on that. There is sympathy for our clerks at our drugstores and in our grocery stores that has been absent. Well, let's try to keep that in mind as we go forward on the other end of this experience. Solidarity, it speaks for itself. I think, there is no regarding this health care crisis as a good thing, but I think we need to remember that good things can come out of it. And certainly solidarity in ways that all of us on the planet have never experienced is one of those things. And we're seeing evidence of it everywhere. We can add to it. And then care for God's creation. And I think I don't need to say anything about that. So with that, I'm going to stop talking about ethics, and I'm sure there are people who have comments or questions about them. Thank you.
Absolutely. Thank you so much, Muiwa, Greg, Nate, and MC. And I would invite Muiwa and Greg, if you want to rejoin us now on video. And as we expected, we are having lots and lots of questions. So I just want to begin by saying we plan to get to as many questions as we can today. Please join us again next Thursday, same time, same channel. The registration for next Thursday's webinar is already live on our website, and you'll be receiving an email to register for it also, because we want to take our time. There are some very, very thoughtful questions here, and so we will get to as many as we can today, and then we will pick up again tomorrow. I do want to let everyone know that as our speakers have been talking and referencing different resources that have been helpful to them, if you are logged on to this event via your computer, you can see in the questions chat box area that we have posted the CAPC webinar that Diane Meyer and Sean Morrison and Bryn Bowman did on March 18th. There's a link to that there. And we are shortly going to be posting the link to the article. I believe, MC, was it out of Mass General? The one you were referencing? Oops.
It was Bay State Health, which is the UMass Medical System.
Okay. We will look for that and we will put it up there. If not in the chat during this webinar, it will definitely be on our website immediately following this event. So let's begin with some questions. Oh, sorry, go ahead.
I'm sending it as we speak.
Beautiful, thank you. So I want to start with one of the questions that actually came up in the news this morning too, about code status. This participant is asking, so what are facilities doing regarding code status? What are the triggers they are using to elevate things for possible reexamination of full code versus no code? What type of criteria are people using to navigate code status in the midst of this crisis?
Are you able to hear me, Denise?
Yeah.
Yes, we
Okay.
are. Thank you, Greg.
So perhaps one of the better policies or protocols I've seen comes from the University of Washington. It's a little bit edgy, for lack of a better term, but it really looks at clinical likelihood that people will do well with the code. So even if we take away the whole question of COVID-19, previously there was some serious questions about at what point should healthcare providers say this is a therapeutic intervention that has so low a likelihood of achieving its desired clinical outcome that we shouldn't even offer it. There are states that have passed laws that prohibit clinicians from making a unilateral no-code decision. But in the face of COVID-19, and in particular the poor outcomes for people who are ventilated with COVID-19 related respiratory failure, there has been a little bit more of a willingness to step up and say, this is not a therapeutically effective intervention, so we shouldn't even offer it. That's not a decision that should be made lightly, and it shouldn't be left upon the clinician at the bedside. Guidelines really do need to be provided at some level, and that's where things like the University of Washington guideline lays out some of the thought processes behind it and helps establish protocols to make sure, again, that this is done in as fair and equitable and just a manner as possible. Also thinking about aerosolization. Talking with somebody recently about a person who was on the ventilator with a COVID-19 related respiratory illness, and the patient clearly was not going to survive, so they made the decision to transition to comfort measures only. They actually elected to not extubate, but simply to turn the ventilator off to diminish the amount of aerosolization of the virus. The concern was that by pulling the ET tube in the standard fashion, there would be a higher level of viral exposure to staff potential. So things like that need to be taken into account as well. Moyowa, I would be interested to see, not to put you on the spot, but I will, to see if you have any thoughts to share along that line as well.
I agree with most of what you said. And I think the other point is there have been conversations with different groups. I'm sure you've seen the Respecting Choices, advanced care planning procedures have kind of been made available at this time to kind of help engage people in these conversations. Now, I've heard there are two sides to this, which is being proactive before you have to go into the hospital and making sure that people are aware of what your wishes are. But then the question is, are you making these wishes now in the setting of a pandemic, and would they be different in the setting of normal life? But I think being mindful, I think what I would say is we encourage each one of ourselves and maybe those we know around us to be mindful of these things right now. We know certain people are at high risk for not doing well. So based on the evidence that's coming out, it's saying elderly people with high blood pressure, with diabetes, with heart disease underlying, if they do end up being intubated, like you rightly said, the chance of a successful extubation or getting off the vent is very slim. So it might be beneficial to kind of start using some of these conversation or communication resources that we have available to us to hopefully start initiating some of these conversations now, hopefully, so that people are aware and know what to expect. And I think it also wouldn't be a bad idea, like you rightly said. So let's say you do have a situation where the person gets intubated and unfortunately now codes, which means they go into a cardiac arrest while on the ventilator. What do we do at that point in time? there's going to be the increased risk of aerosolization, like you rightly said. And so is this a situation, normal code situations, you call a code blue in the hospital, everybody rushes in. The reality right now is that is probably not going to be feasible because of the conservation of PPE that's being seen in a lot of places. And so how do we handle that? So there's going to be a need to kind of start having thoughtful conversations about that in our various organizations, and making sure that everybody is comfortable. These are emotionally laden conversations. And I think it's a time where we might need to have to step up and be forthright right now and not kind of shy away from having those conversations.
Thank you both. I think something that I assume we're talking about the Washington Post article that was just out today, discussing DNRs. And, some of the, when we look at the policy, so yes, University of Washington, the state policy for Washington is very well thought out. Others like the state of New York, state of Minnesota, state of Utah, first you got to look to see what is your state policy. A lot of that is not only how you coordinate amongst your facilities within that state, but also about legal and liability issues. So yes, as Greg pointed out, some states have restrictions against unilateral DNRs, and some of them have policies on how to implement them. Will those change during a crisis? We're waiting and see. In the Washington Post article, the question was raised whether a COVID-19 positive status would immediately make you a do not resuscitate. I have yet to see anybody that is arguing for that or a policy that is stating that. I think to Greg and Muia's point, they're modifying the way that they are providing a code. They're modifying who goes into the room, the ways that they do it, ways that we can try to lower the spread. We're trying to adapt our procedures so that we can continue to provide the service going forward. One question, though, that I do see in policies that I think is something that can be discussed is whether during moments of actual triage, when you're deciding who will receive an ICU level service and who won't, if somebody is deemed too critical or their score is too high on whatever criteria they're using, or the likelihood of success even with critical intervention is so low, those people we may then discuss, if we're not going to provide them an ICU bed and we're not going to be able to provide them a ventilator because of how critical they are, then we may need to discuss making them a DNR at that point. We've already determined that the level of success is very low. We have transitioned them into palliative care and comfort care, comfort measures only. And therefore, would it be appropriate to have a very strong conversation at that time to say we will also not be, code status will be a do not resuscitate for those particular individuals already triaged out of the ICU. I think that is where the conversation and the policies are focused on, not on everybody that comes out COVID positive, but rather that particular group of people who are so critical that intervention is not going to be beneficial.
Right. I would add to what Nate has said two things. First, I would underscore it ought not necessarily to be presumed this is an all or nothing decision, that this requires greater nuancing, even though we are talking about broadly applicable policies. So I would underscore that. And beyond that, I guess I'd just underscore everything you said, Nate. But yeah. Let's go to the next question. I think we've talked about this one enough.
I always appreciate an ethicist supporting a fellow ethicist at all times.
Underscoring what Nate said is generally good policy.
You can't go wrong there. You can't go wrong. So again, I think to our participants, the abundance of excellent questions, I again encourage all of us to come back Tuesday, because I am seeing entire threads of discussion that I know we won't get to today, given that we have about 9 minutes left. So staying in this thread, because I think we're talking very close to it. So can you address the issue of triaging care in general? So we've kind of talked about that with regard to code status, critical care beds, ventilators, and there are practices, hopefully, that can help systems, teams, providers prepare thoughtfully for issues like these ahead of time.
Who's going to start off this one?
I'll start in a very broad sense. I think, again, emphasizing that many states and many government organizations and departments, as well as systems, began planning a procedure around an influenza pandemic about 10 years ago during the H1N1. So the idea that we are just making this up right now is not reality. That we have had groups of people, massive groups of people, for broad swaths of professions, but stakeholders as well, who have spent time really thinking and developing procedures and policies for a moment just like this. It's something we should really start with. You know, it's go and look and see if your state has a policy and procedure in place. If it doesn't, I recommend looking at, again, the states I mentioned, Washington, Minnesota, New York, for example. Many states are actually just copying and pasting from those three states' policies to get a sense of not only around what triage protocols you might have in place, but more importantly, they spend a great deal of time around preparation. You know, we are right still at the moment that we can in some way prepare for a surge or for a transition to a crisis standard of care. And if you haven't listened to it or you were unavailable to be on the webinar that the Catholic Health Association put on yesterday with Rhonda Meadows from Providence and their response to the immediate need in the states of Washington and California, for example, what are some real practical ways that you can already begin preparing for a potential surge? Not only around resources, but around education of your staff members, around getting these policies and procedures to the front lines. Because I think when I've looked at media and newspapers and, you know, the articles that are trying to address the ethical concerns, I always feel that they're somehow interviewing the one person who has never read a policy or who is not the most adept at the procedures that are in place, who just haven't been informed yet. And so we have a duty upon ourselves as leaders and professionals to really go out and be informed and then to educate our colleagues. And I think to Greg's point around palliative care really is going to have to educate our colleagues about how to manage triaging, how to manage people who are placed in critical care situations, how to care even when we cannot cure. So, you know, we have levels of preparation in place. We need to do better at informing ourselves and others at it. I think that's where we have to at least start.
That's lovely, Nate. I really appreciate that. One of the things that struck me is this Downer article I shared is from 2010. You're right that a lot of this, we're acting like we haven't thought about it before, but after H1N1, many of us did develop local institutional policies to prepare ourselves for a pandemic. And many of you have actually seen some of the material that Bill Gates, not in his retired Microsoft role, but in his Gates Foundation role, in 2015 really accurately predicted that a viral pandemic in the setting of globalization was going to be one of the next public health catastrophes we would face. And sure enough, here we are. I like that you referenced the system approach, you know, using like Rhonda Meadows and others, because we've certainly done a lot of work within Providence St. Joseph Health to make sure that we have some system level guidance. That said, then you need to take it to the regional level to develop your triage teams and your local and regional protocols. And then at the point of care, having administrative triage teams or others to really help design for the emergency department, the critical care unit. How are we going to deal with this? And then who is on those triage teams? Is it going to be your CMO, your CNO, your director of ethics, case management, and so on? we have actually really leaned away from, and you would have heard Sean Morrison say this on the CAPC webinar last week, having palliative care providers up close and personal to rationing or allocation decisions. Some of that's the historical concerns over being rebranded as death panels and all of that. But truthfully, the frontline clinicians, emergency providers, critical care docs, hospitalists in particular, are probably the ones who are the closest at understanding the clinical scenario well enough to say, now, how do I take this guidance that my hospital or my region or my system has put together and apply it to this patient? Because ultimately, every one of these decisions has to occur with each individual patient. But we can't leave our frontline clinicians hanging without clear guidance that provides them a solid foundation so that at the end of the day, they know I wasn't alone in dealing with this. My organization actually provided a framework where I could do this with integrity. And even if the decision is harrowing and the outcome is undesirable, that I know the process set me up to do it in a manner that I can live with. So that to me is a real critical portion of this.
Just to jump in quickly too, I think one of the points you made, Greg, was the local and regional collaborations, because I think, yes, SCC, we're looking at the Supportive Care Coalition, which is Catholic healthcare systems providing palliative care. But we would find that some of our hospitals are in towns or cities where we're not the only hospital, and we have other hospitals around us. And so I think part of that local collaboration might be to reach out and figure out what's going on. So kind of everybody's on the same page, and you know who's doing what and how you can kind of work in terms of what are the resources available outside of your hospital walls right now. So I've been following a conversation. I'm sure, Greg, you've seen that about the role of hospice in all of this. There's a conversation going on the AHPM Connect right now. I mean, like anything else, I mean, people have seen hospices as maybe like the final stop, but you know, it might not have to be that. So how do we support the hospices? Because right now they're having the issue with PPEs. Some locales have hospices that have inpatient units. How can we support them in making sure that they are able to do that triaging on their end as well? Because some places right now have shut down their doors, you know, because they're not accepting patients. And some, unfortunately, have accepted patients that have put their staff and themselves at risk and the other patients there. So how do we navigate all of that? I think these are some of the things that we might need to think of in the framework of what you had referred to earlier on, and putting the triaging cap also in place.
If I could just interject one thing on behalf of the people we serve, and it is not directed to the healthcare workers per se, the folks who are in the hospitals delivering this care, but the whole notion of rationing and triage is bandied about in the public media very often because it's a reality, and it's a reality we all need to deal with. But what would be very helpful, and I'm saying this more for the folks on the call than for either of our two clinicians here or their compadres, it would be really helpful if many of the advocacy and public outreach groups could maybe look to some of the more responsible sources about what triaging is. You know, Nate has given an example of some stuff that has been done by CHA well in advance, as did Greg. This is not a new topic, and the reality is we're just implementing long thought out and long discussed practices and policies. So some way to perhaps educate our public who are the family members or will themselves be the patients that are subject to this about what it is and how it works, and how carefully their individual needs are respected and considered and play heavily in any of the decisions as triage gets implemented. I think part of what we're seeing is the fear of the unknown, and the word rationing of healthcare has always been used in such a negative context, and there's not a lot that's good about it, but at least if people understand it. So this is kind of a call out to some of the folks who are perhaps listening and participating with us today to think about this. I know we are at the Archdiocese.
To your point, MC, one of the aspects that I think we could use a little bit better preparation for as this time comes is communication skills around, this is the policy that's in place. This is how we're going to triage. This is how we're going to evaluate your loved one right now. This is how we're going to evaluate them again, potentially in 24 or 72 hours. That some systems have already begun actually scripting out what is it that we're going to say to patients, to their family members, to each other, because it is a sense of fear that the unknown, that there's some sort of panel of people, or that there's some sort of algorithm that we're unfamiliar with that's going to decide. So how do we communicate that, again, we are upholding our traditional values and ethics at this moment, and we want to make sure people are still understanding that we're still here to provide care, we're still here to accompany you, we are still here to be a Christ-like presence for you if we're Catholic healthcare, and this is just how it's going to look in this moment of crisis.
It occurs to me, Nate, that a lot of the people who, certainly in the states where we have stay-at-home orders or are being encouraged to work from home or are being left out of the hospital kind of hierarchy in an effort to close the doors to increasing contagion, a lot of the people from pastoral care departments and from some of the communications people, as you noted, they could work on this. They could work together on combing the literature, coming up with these kind of scripts, these few frequently asked questions pages for hospitals. Folks are trying to figure out, how do I carry on in the face of not being at my desk or not being able to maintain my routine? These are projects that people should be looking for and implementing.
So well said. I think we could easily go on for at least one more hour. Just for everyone who is on this event today, know that this has been recorded. It will be sent to you via an email link shortly after this webinar concludes. And I can just say, for those of you who are able to rejoin us next Thursday, same time, we will be talking about all of the questions we didn't get to, many of which fall under, I would say, the umbrella of moral distress. Questions like that tension between my own personal safety as a caregiver taking care of potentially COVID positive patients versus my duty to care, versus that guilty feeling I have when I do something to protect myself that might limit the amount of patient care that I provide right now. We have a large umbrella of questions around workforce issues. We're hearing from solo providers who are on their own, the only palliative care person in their setting. We're hearing about discipline-specific issues from social workers and chaplains who their MO, their way of being, is a ministry of presence. There are great challenges to providing that ministry right now, not excluding sacramental ministry. We also have workforce issues around deployment and redeployment. How should palliative care clinicians respond to requests to be redeployed right now? And what does that mean? Are we essential in palliative care? Are we essential to switch back into our other board certified specialty? And then lots and lots of questions that I would say fall under the umbrella of the social teachings that MC and Nate highlighted so beautifully about human dignity and justice. So we have lots of questions and comments about bias against immigrants and refugees. We have comments about ageism and how that is playing into this discussion. So I say all that as a preview of the things that we will pick up on and get to on April 2nd. So I do invite you to rejoin us then and rejoin this panel. And again, looking off a week further into the future, we do have Dan Silmacy, a physician and ethicist from the Kennedy Institute, who will be joining us on April 9th. And that entire hour will be Dan walking us through, in his clear-headed and brilliant, just like MC and Nate do, grounding way to orient us around our tradition, our teachings, and the wealth of tools we have to address questions like these. So again, there will be a survey that will come up at the end of this webinar. We invite you to complete it. We use it to plan future webinars. For those of you who have typed questions into the question box, we have captured every single one of those, and we will do our best to get to all of those. And the resources that our speakers have mentioned that you have requested, please check www.supportivecarecoalition.org and our COVID-19 resource page, and we will be updating that minute by minute as we add the resources that we've captured from you all and from our presenters today. So with that, thank you very much. We will regather again as a community on Thursday, April 2nd.
Thank you.